Good morning to everyone, and my topic for today is management of fundal varices, glue versus coil versus PARTO. I have no disclosures. The contents would be as an introduction, classification, and I've divided the presentation into three arms, which is either in an active bleed, primary prophylaxis, secondary prophylaxis, and a proposed algorithm which I've proposed at the end of the presentation. So coming to gastric varices, as we all know, the incidence is around 20% in cirrhotic patients. And more importantly, the bleeding in gastric varices is most closely related to the size as well as the wall tension of the varix and not necessarily on portal hypertension. And that is the reason why most of the modalities like beta blockers are not very effective in patients with gastric varices. The 6-week mortality is close to 16 to 25%, and it can also increase to nearly 40% if not treated at an appropriate time. So coming to the classification, and I think this is the most universally accepted classification all across the world. And this classification, the Serines classification, divides the gastric varices into gastric varices type 1, type 2, and IGV1 and IGV2. The relation of the anatomy is that the gastric varices, which is type 1, is closely related to the left gastric vein, whereas GOV2 and IGV1 are related to the short gastric as well as the posterior gastric vein, which again helps us to decide the therapies in these line of patients. The other classification is based on a CT scan, and these are based on the afferent as well as the efferent pathway, known as the Cadwell classification. This is more commonly used when you're using more interventional radiology procedures. As you can see here, this is the left gastric vein, the short gastric vein, as well as the posterior gastric vein, which lead to the formation of various types of gastric varices. So the classification of gastric varices based on presentation are on three types. One is if you're in a situation where a patient has come with active bleed, or if a patient has a large gastric varices with all the high-risk outcomes, and what do you do at that point of time? And secondary prophylaxis, which is a more common scenario where the patient already has a history of bleed, and how do you treat these patients? So this was a small data that we've presented on splenic stiffness, and we looked at all the bleeders that had come to the emergency, and these are nearly 700 patients. And as you could see, the incidence of gastric varices in bleed was nearly 35%. And even in non-bleeders, the rate was nearly close to 10%. Requiring endoscopy as well as endotherapy was in nearly 80%, and the other modalities, which included an EUS guided coiling, a BRTO or TIPS, was in nearly 19% of these patients. So thereby signifying that there are multiple modalities that are required for the complete obliteration of gastric varices. So this has been summarized very well in this beautiful article by Dr. Chitranshu, which has shown that these are the various modalities that can be used for gastric varices. That starts from an endoscopic glue, an EUS guided coil for the gastric varices. You have an BRTO, which is transferred from the gastric vein, more commonly for the gastrorenal shunt, and causes an occlusion. You can also use TIPS, which is more for decompression if there is concomitant esophageal varices, though data is not very convincing on that part. And of course, there are the conventional beta blockers which are required for the reduction, though the significance of that in gastric varices is still debated. So the first modality is if a patient comes to you with an active bleed. What do you do in that scenario? I think even till today, I think everyone agrees, or most of the guidelines agree, even the latest ESG or the Bivino, that glue, which is cyanoacrylate injection or N-butyl cyanoacrylate, is the modality of choice in this scenario. Would you use the other modalities like an endoscopic ultrasound or a BRT on this scenario? Well, still the data is not very convincing on that. The results of glue while a patient has bleeding varices has been studied over the last 20 years, and most of these studies have been retrospected, except for the one which was done as a randomized control trial from GB Pant, which had shown an hemostasis rate of nearly 89% and a rebleeding rate of 22%, and then another study in 2001 which has shown a rebleeding rate of nearly 31%. So it comes to the point that there are very few randomized control trials to actually give us the exact clue, but endoscopic therapy for active gastric varices remains the mainstay of treatment. So coming to the next question, in an active bleeder, what if there is a failure of endoscopic glue in these patients? So the ESG recommends that there can be a rescue TIPS or a BRTO for gastric variceal bleed where there is failure of endoscopic hemostasis. It is still a weak recommendation. The Bivino 7 has also classified that in patients with GOV2 as well as type 1 gastric varices, BRTO could be considered as an alternative to this treatment, provided that there are shunt and the diameter of shunt is significant as well as local expertise. So in all, most likely the most effective treatment for achieving hemostasis at this point of time remains the endoscopic glue at this juncture. So primary prophylaxis, again a very debated topic because there are very few studies on this. And for primary prophylaxis for gastric varices, these are some of the risk factors that are involved. One is the location of gastric varices. the size of gastric varices, which can divide into large, medium, or small, severity of liver failure. So MELD score of typically more than 17 is considered to be a high-risk varices. The endoscopic presence of red spots, HCC or presence of PHG have been shown to have higher risk factors or higher rates of bleeding in this group of patients. So the only randomized control trial which has been done in gastric varices primary prophylaxis was again from GPAN from Dr. Mishra also, which had compared glue versus beta blockers versus no treatment. They had shown that if cyanoacrylate glue was used for primary prophylaxis, the rate of bleeding was only 10%, whereas 38% with beta blockers, or nearly 53% if no treatment was given to these group of patients. This study also concluded that there was a survival benefit, even though mortality benefit could not be seen. But glue remains one of the most standard treatment that can be given for patients with primary prophylaxis. So this was a case that came to us, and this patient had large gastric varices, as you can see, nearly more than 20 mm. He had not a significant shunt, so we decided to do an endoscopic glue. As you can see here, this is the catheter which has been employed. We do it mostly on the peripheral part of the gastric varices. We injected close to 8 ml in various parts of the gastric varices. Until now, the patient has not had an incidence of rebleed. This patient is almost nearly 1.5 years of follow-up, showing that a good endoscopic glue is also a very good determinant for prevention of rebleed in these group of patients. So the reason why endoscopic glue sometimes has been considered, and there are other forms of modalities which can be considered, is the risk of certain complications which have been described in literature, more commonly embolism. As you can see, most of the embolism, which could either be a cerebral embolism or a cardiac embolism, it could be infection, though the rates have been described in various studies of nearly 5% to 15%. In clinical practice, they are more or less than 2 to 3% in most of these groups. Hence, the need for other forms of therapy has been described, and one of that is endoscopic ultrasound. And as you can look here at the endoscopic ultrasound, this is how a gastric varices looks while you are doing an endoscopic ultrasound. This signifies the perforating vein, as well as this is the gastric varices. You then inject using the FNA needle, normally a 19 gauge FNA needle, and this is how it looks on a fluoroscopy. It has been seen that there is a better obliteration with endoscopic ultrasound as compared to gastric varices endoscopically. This is some of the techniques which are used. Some of the techniques which are used also have to be that you have to have a very closed gap. It should not be very far away. Most of these varices should be extramural. There should be sufficient insufflation of water while you're using these gastric varices. And it is always to be kept in mind that the needle has to be protected while you use glue in these case scenarios. So for primary prophylaxis, the study which was done in 2016 was EUS guided treatment of gastric varices. This was again a patient of 152 patients, retrospective analysis. Most of these patients were for secondary prophylaxis, though they did use for 7 patients with an history of active bleed at that point of time. They used coils, and the coils that they showed was nearly 1.4, and the mean volume that they used was 2 ml. It should be noted that in the US, N-butyl cyanoacrylate is not approved, so they use 2-octyl cyanoacrylate, which has a higher polymerization time as compared to N-butyl cyanoacrylate. The complete obliteration was seen in 93%, and 96% had achieved complete obliteration, thereby suggesting that EUS-guided therapy was better as compared to endoscopic therapy, but there was no survival or any benefit as compared to when you compared both the therapies on its own. Again, the same group took their study forward, and in 2021 they published another data where they looked at 80 patients. They used patients who had high-risk gastric varices divided by the size of gastric varices with an history of red spot. They also had an history of esophageal varices hemorrhage. The MELD score was between 10 to 18. The mean varicose size was more than the normal risk factor, which was 2.2 mm, and varicose obliteration was nearly 94%. And they suggested that EUS-guided therapy was highly effective in preventing gastric variceal bleed. Again, this was a retrospective study, more of an observational study over a data which was collected over 8 to 9 years. So then coming to the other form of treatment that we have discussed is what would be the role of a BRTO in a scenario of primary prophylaxis. And this study, which was published in 2022 in Hepatology International, looked at a scenario where they compared BRTO as compared to endoscopic therapy. As you could see that the gastric varices disappeared completely in 33 patients, which was 45% in endoscopy and 75% in BRTO arm. The patients who received endoscopy or a BRTO developed less bleeding from gastric varices who were only observed, thereby suggesting that some form of therapy was always required, whether it was endoscopy or BRTO, but it must be kept in mind there was no mortality benefit or even a risk of bleeding events were comparable in these group of patients. So thereby suggesting that both these therapies still require a better randomized trial to tell us exactly the nature of these therapies. So this is a thesis which is ongoing at this point of time, where we are comparing BRTO versus the endoscopic therapy for primary prophylaxis in patients with large shunt, a group of population which has not been studied. The study is ongoing. Nearly 14 patients have already completed the study, and it would be completed forward. So to summarize primary prophylaxis, I think this is very aptly put in another article. The choices need more testing. That means there are less of randomized trials. The risk of benefit of using upfront BRTO versus an upfront EUS guided coiling, it still has to be debated. The presence of shunt, so if there is a significant shunt, do you go straight away and do a BRTO as compared to an EUS guided coil? The expertise of a center, do you have all these facilities at that point of time? And if there is a presence of esophageal varices, then in most likelihood a primary BRTO may not be done, and you'll have to probably do a TIPS compared with a BRTO or go in with an endoscopic ultrasound. So primary prophylaxis is still in an area which requires a lot more studies to actually tell us which exact way that we need to go. Secondary prophylaxis is a patient who has already bled and presents to you. And in this scenario, well, the only randomized trial which had shown that endoscopic cyanoacrylate versus beta blocker for secondary prophylaxis had shown that cyanoacrylate was more effective than beta blockers for the treatment of prevention of gastric varicose bleed and improving survival in this group of patients. When you used EUS guided and you used EUS guided coil versus endoscopy, it was seen that in 30 patients, the gastric varicose obliteration was 94% in the EUS arm and nearly 91% in the endoscopy arm. So they thereby said that the EUS arm required fewer endoscopies, lesser adverse events, though the number of adverse events in this group was only 6% in the endoscopy group as compared to the EUS group. This was a trial this is a propensity score matching which has been done from certain centers of India as well as Italy. These centers used 276 patients of EUS guided coiling and compared it with 118 patients with propensity match scores of endoscopic cyanoacrylate. This did show that EUS guided therapy had significantly lower number of sessions, as well as requirement of subsequent bleeding episodes, lower interventions, but there was no difference in the survival in these group of patients or any need for any increased risk of decompensation in any of these patients. There was a meta-analysis which was published, which looked at all the studies which have looked at endoscopic ultrasound-guided therapy versus endoscopy therapy. Again, the conclusion was the obliteration rates were higher with an EUS group. The recurrence was lower, the long-term rebleeds were lower, but the survival continued to remain the same in both group of patients. So this was a patient who came to us a couple of months back, and this patient had undergone 3 sessions of gastric varicose hemorrhage. As you can see, these are the gastric varices. The size of the nature of these are very small in nature, so it becomes very important to first insufflate the EUS with lots of water to first demarcate the extramural as well as intramural gastric varices. These are the gastric varices as we can see here, and this is insufflation being done. Once the insufflation is done, it is important to measure the size of the varix, because again a controversy exists in EUS guided therapies whether you use just glue, do you use coil plus glue. Right, yeah. So these are the gastric varices as you can see here. This part here, as you can see, the size is smaller because this patient has undergone 3 sessions of endoscopic guided therapy. And once this is done and we have insufflated with water, we can clearly see here this size. Now we'll measure the size of the varix, and the size of the varix was close to 6 to 7 mm. So we decided that instead of placing a coil, we'll go straight away and just do an endoscopy glue, because the size of the varix was small and sometimes there's difficulty in deployment of the coil while you're using in endoscopy therapy. And once this was done, there was complete obliteration which was seen. Yeah, you can see, this part here. So it was decided that we'll inject on the part which is furthest from the distance over here, and there is some problem in the video. But the patient was able to achieve complete obliteration of the gastric varices, and the patient has not bled. There's been 3-month follow-up, and the patient still has not bled at this point of time. The next important question that I was proposing was EUS guided coil or glue with coil. And there has been a systemic review which has seen whether you use just glue with EUS or coil with EUS, and they have suggested that a combination therapy could be used for coil embolization as well as with glue injection. However, the size of the varix is very important. This is still an expert opinion of various experts that says that if the size is less than 5 mm, you just go ahead and place glue, whereas if the size is larger, you go ahead and place a coil. On the left hand side, you can see this is the coil, and the basis of coil uses it acts as a scaffold. So when you place the glue, it acts as a scaffold, it prevents the glue from actually going into the shunt and thereby preventing the complications that have been suggested post endoscopic therapy. But however, like I said, whether the presence of shunt would determine that you need to use a coil or the varice size is something that still needs to be answered. So coming to the third part, which is BRTO, which is balloon retrograde transverse obliteration. This was introduced in 1996. The indications include gastric varices, whether it's for actively bleeding or primary prophylaxis, somebody who has refractory hepatic encephalopathy. The contraindications include if the patient has high-risk varices. These are relative because you can do a TIPS in that sense, or if there's complete portal vein thrombosis. As you can see here, this is the catheter of the BRTO, which goes via the left gastric vein. The most common shunt which is done is the GR shunt, which is the gastrorenal shunt in nearly 85% of. Yeah, this is the balloon which is used to occlude the varices over here. This is normally placed post-procedure about 4 to 5 hours. And a sclerosant is also used, which is known as sodium tetradecyl acetylate, and that causes the complete obliteration of gastric varices. The issue being that once this is occluded, that can also lead to a higher pressure formation, and it can increase the HVPG by close to 44%. And that is the reason why there can be a higher incidence of ascites and as well as esophageal varices post-BRTO. So one of the other techniques that have been described is the plug-assisted retrograde transverse obliterography. And as you can see here in the plug-assisted pancreatography, this is the vascular plug that is being used. Because in a BRTO, when you're using a balloon as well as a sclerosant, there can be damage to the endothelial lining as well as the rupture of the balloon. So it was suggested that using a plug may even alter these mechanism. Also, the procedural time required for a PARTO is much less as compared to a BRTO. So hence, PARTO is also one of the now commonly used modalities while you're assessing for BRTO. So when they compared BRTO versus endoscopic therapy, and this was published in 2019, again for secondary prophylaxis, there was no difference in 1-year mortality when you compared both the arms. The rate of rebleeding, though, was slightly higher in compared with endoscopic therapy, but there was no difference in either survival or in mortality benefit when you compared both these arms. And the long-term follow-up was not available for the BRTO arm, which possibly after a couple of years with the rise of HVPG and portal pressures, there could be a higher incidence of ascites as well as esophageal hemorrhage. So the guidelines on secondary prophylaxis still do not give us a very clear picture. ESG says individualized approach, lack of definite evidence. ASLD says TIPS or BRTO as first line of treatments of prevention of rebleed. It's a weak recommendation. So again, these forms of therapy, even though in secondary prophylaxis have been studied, because of a lack of RCTs in this group of arms, it is still very difficult to suggest one over the other. Now, as I discussed BRTO versus PARTO, in fact, there are 4 of them. There is BRTO, there is PARTO, there is CARTO, or there is BARTO. The difference being this includes a balloon, which you need to insufflate the balloon, and then the risk being that there can be a balloon rupture as well as using a sclerosant. PARTO does not use a balloon, it just uses a plug, and you normally use it for size less than 18 mm. Whereas when you use CARTO, which is coil assisted, the size of the shunt can be larger. So it can be 25 to 30 mm where you can use. And BARTO is when you do not have the presence of a shunt and you go percutaneous via the portal venous system. So summarizing that, I would say there are more questions than answers even in secondary prophylaxis. The guidelines, the appropriate modality. Do shunts change the management even for secondary prophylaxis? Do you go upfront for a BRTO versus endoscopic therapy? The expertise and cost also are very different for all the 3 therapies, an endoscopic therapy versus an EUS versus an BRTO therapy. If you have presence of ascites or varices, do you go for TIPS followed by BRTO, or then you go in for an endoscopic therapy? And again, these 4 modalities which I discussed, BRTO, PARTO, which, when and how is again important. So again, there are more questions than answers in this group of patients. So this is a proposed algorithm that I think after reading the guidelines. So if a patient comes with active bleed, I think endoscopic therapy with glue and beta blockers still continues to remain on the forefront of the treatment. If there is failure to control bleed, possibly consider TIPS or BRTO in this situation. EUS therapy can be considered, but yes, it is still a very difficult modality at that point of time because there could be a lot of blood in the fundus and could become difficult to visualize. Second would be if there is patient with an history of bleed and repeated bleed. So this is for secondary prophylaxis. For secondary prophylaxis, you use a CT imaging, look for shunts, significant size of shunts, look for esophageal varices, ascites, severity of liver disease, the bilirubin levels. If there are varices, there is ascites, bilirubin of more than 3, child B cirrhosis, whatever be the size, shunt size, in most likelihood you cannot use a BRT on this scenario. So use either EUS versus repeated endoscopic glue along with beta blockers. The second scenario is if there are no varices, there is minimal ascites or no ascites and bilirubin less than 3 and a significant shunt size or more than 8 mm, you can consider a PARTO or BRT on this scenario versus an EUS. Now, if there is a primary prophylaxis where there is no history of bleed, you look for all the high-risk features for gastric varices, which has already been mentioned. You look for the shunt size. You look if the shunt size is more than 8 mm. There is history of hepatic encephalopathy, as well as there is no varices. Or you look at a shunt size which is less than 8 mm and varices. You consider either BRTO versus beta blockers, or you go ahead and do an EUS versus an endoscopic therapy, depending on the scenario. So my take-home message would be that the management of gastric varices continues to be a multimodal approach. In acute bleed, endoscopic therapy remains the mainstay of treatment. Once bleed is controlled, depending on the severity of the liver disease and condition, EUS or intervention radiology procedures can be considered. High-risk gastric varices who have not bled should be treated after assessing all the risks and benefits of all the 3 modalities at that point of time. And again, the randomized control trials in all the 3 arms is probably the need of the hour. Thank you.